So best practices for using soft tissue mobilization. We are using soft tissue mobilization to, again, decrease relative tension, improve proprioception, alter their perception of pain, and using soft tissue mobilization to achieve those results is just one piece of the puzzle to get us to the bigger picture, right? Moving better, moving without pain, and getting them into a position where they can tolerate load. And how we choose to use these different modalities is important in that there is no real consensus right now in the research saying that this is the only way to perform this procedure. But how we go and explain the procedure will dictate the kind of the results we get from doing that procedure. So if we're taking foam rolling and we foam roll the anterior thigh, okay, so we're foam rolling the quadriceps muscles. If the patient's applying all their body weight to the foam roller and they're laying on top of it, and that causes them discomfort, a great amount of discomfort, naturally they're going to contract their quads and they're going to try and remove some of their body weight from that. So they're going to try and lift their body weight up off the foam roller. Okay, it's a withdrawal mechanism. It's causing that much pain that they're trying to avoid it. And generally, if they're going to foam roll and they're in that much discomfort, they're going to foam roll quickly and they're going to go back and forth because they don't want to stay in one spot, because that staying in that one spot causes a tremendous amount of pain. All right. Because they're contracting their quad and there actually is causing some pain to it, and they're being quick about it, and they're trying to just get this kind of therapy done, they're upregulating the system, and they're probably causing some kind of reciprocal inhibition because they're contracting their quad so tightly. They're probably inhibiting the hamstrings and the posterior chain, right? So we've kind of turned on the quadriceps a little bit, versus if we said, hey, let's foam roll. We want you to do it in a position where you don't have to put all your body weight on it. We're going to put you in a position where you can actually tolerate resting on it and you can relax. Maybe we're going to use some breathing techniques. I want you to exhale, and we just want you to relax into it. And you can actually tolerate the pressure that's there. And we're going to do this in a slow fashion. Okay, so I just want you to sit there and just kind of spend a minute in that position before you move on to the next position. That can actually down-regulate the tissue, and it's not causing this withdrawal reaction where they're like, oh, I'm in so much pain, I want to kind of get done with this. So they can relax and take their time with the modality. And again, we're going to inhibit the quads. And if we inhibit the quads, we see that through EMG studies that automatically the quads or the posterior chain, the glutes and the hamstrings can turn on, right? There's more activity to them. So again, it all comes down to how we've explained the procedure to the patient. Versus if we say, hey, take a foam roller and go kind of roll at your quads, then we don't know what result we're going to get. Are we going to get an inhibitory or a facilitated response from that? Okay, so we're applying these, again, knowing kind of what mechanoreceptors we are stimulating and how we stimulate those is important, because basically, again, every patient's going to respond differently. Some people are going to like, a slow kind of controlled type pressure. Some are going to like kind of a quick kind of feathering technique, right? So we are using these to, again, get the result we want in the context of a treatment plan. So what are we trying to achieve by doing this? Do we want relaxation of the hip flexors and the quads? Because in the study that's there in the notes, basically they were evaluating the difference between a single-handed and a two-handed kettlebell swing. However, what they found over the course of this study is that they were measuring hip flexor length. So doing a modified Thomas position, they were assessing how much hip extension they had and how the muscle length of the anterior thigh. And anybody who had a tighter hip flexor produced less hip extension force. So they were less explosive through the glutes and the hamstrings. So again, that's just reciprocal inhibition. So if we were trying to fix that or change that so they could actually produce more force and power in their hips, then we'd want to do some kind of inhibitory soft tissue mobilization technique to the anterior thigh, maybe follow it up with a stretch, and that should allow them to produce more force to their hips. That's all in context of a treatment plan. If we thought that was the issue and that was playing into the patient's problem, then that's kind of the model we'd want to go through. Oftentimes when people are going through and applying foam rolling, soft tissue mobilization techniques, active release technique, they're extremely aggressive, and that there's this no pain, no gain type mentality to it, and that we're trying to get to deeper structures, and there's a lot of force, or we're trying to irritate tissues, or cause an inflammatory reaction, or bring blood flow to the area, right? Again, you got to get away from the mechanical component to this and think more sensory, right? So the pain isn't required. Having deep pressure means that you've gone through the superficial tissue, and the superficial has changed and relaxed, allowing you to get to deeper tissue without the pain. If we just try and fast forward and get past that superficial tissue and get to the deeper structures, yes, it's going to cause some discomfort. So we need to take a kind of a slower approach and not be concerned about, hey, is this causing some kind of skin reaction? We're not going to achieve anything unless we see a bruise, right? It's all comes down to, again, letting the patient adapt to what we're doing. So do they sense changes with light pressure, light feathering techniques, and that allows us to get to something maybe more aggressive, again, with less pain. Now, when we're performing these soft tissue mobilization techniques, a lot of them should only last a few minutes. It doesn't take a long time to actually perform these techniques. And that we're not seeing any evidence in the research saying that we're getting any added benefit to performing these procedures beyond 5 minutes. And that once we've gone through and we've seen these changes, they're generally short-lived, and that we're not seeing the changes continue much past 10 minutes. So that 10-minute mark is, again, another window opportunity for us to kind of achieve some rehab or some stimulus to the patient that allows them to get into a different position that hopefully carries over into maybe a long-term adoption by the patient.